Great, thank you. Well, good afternoon, everyone, and welcome to Trust for America's Health's AIDS-Friendly Public Health Systems monthly training series. It's August, and a lot of our friends are on vacation, so we're really happy that you all are here to join us today to learn more about how the public health sector can support older adult health and well-being. My name is Megan Wolf, and I'm joined today by my colleague, Dr. Karan Phillips. And our APHIS movement would not be possible without the generous support from and partnership with the John A. Hartford Foundation. Next slide, please. So again, we ask that you all please keep your devices muted during the presentation today so we can avoid any background noise or disturbance, but we understand sometimes our dogs don't cooperate with that. So we may even have to mute ourselves at some point, but we do ask that if you have questions, feel free to drop them in the chat and we can we'll collect them and get to them toward the end of the presentation today when we'll have time for some discussion. Next slide, please. All of our APHIS trainings are recorded and the slide decks are shared with our registered attendees after the training. If you are using an AI note-taking tool, please let us know by commenting in the chat before our speaker begins. And in addition, you must be present in the training with the AI note-taking tool. Notes generated from any AI tool can only be used for your personal use. Next slide, please. Your feedback is really valuable to us, and it would be very much appreciated if you would take a few moments after the training to complete an anonymous feedback survey. It will pop up at the end of the training on your screen. Your insights will be shared with our evaluation partner at the New York Academy of Medicine and will really help us in enhancing future training. So please be sure to complete that for us. Next slide, please. So as most of you know, TIFA is a public health policy research and advocacy organization dedicated to optimal health for every person and community. TIFA produces several reports every year. This is kind of what we're known for. And we also have a number of reports and briefs on healthy aging on our APHIS website, including the one that you see here on the screen on aligning our APHIS 60s framework with the 10 essential public health services. So again, you can find those on the TIFA website under reports or on the APHIS website under resources. So next slide, please. So this year, our monthly trainings have focused on the AIDS-friendly ecosystem, and we've been very appreciative of the participation by many of the authors of the articles that were published as part of the spring edition of the American Society on Aging's Generations Journal, and that was on the promise of an AIDS-friendly ecosystem. Today, we're delighted to be joined by Dr. Deborah Carr, Director of the Center of Innovation in Social Science and ANS Distinguished Professor of Sociology at Boston University. Dr. Carr is a contributing author to our journal. And today we'll be discussing the importance of addressing systemic disparities to improve health outcomes for older adults. So welcome, Debbie. We're so happy to have you. And we'll take our slides down. You can start yours and we can get started. Thank you so much for being here.
Great, and thank you for including me not only in today's webinar, but also in the really fantastic issue, which I am assigning some of those articles to class this semester, my aging class. So it's really been a privilege to be working with you in both of those capacities. And thank you, everybody, for showing up on this August day. I hope you're all safe from the storm. I see trees blowing outside of my window, but hopefully we'll all keep healthy, for the next 45 minutes. And so it's really my pleasure to chat with you today about the topic of inequality in aging. And some of this may be familiar to you. I hope there's some new material and really thinking about diversity among the older adult population, where those sources of inequality emanate from, how they bear on our lives. And then I'll wrap up thinking a little bit about what might inequalities look like for future cohorts of older adults. And as an aging scholar, this is a question I often get a lot. Much of what we know about old age is based on the greatest generation or increasingly the boomer generation. But how about Gen X and millennials? What are some clues that we might have now that help us think about what aging and health will look like 10, 20, 30 years down the pike? So I'll be wrapping up with that. So in just one moment, I will put my slides together. Oops, share. Great. And can you all see my slides? Okay. Perfect.
Yeah,
I'm going to try
looks
to
good.
hide that top bar now. There we go. Perfect. Great. And so what I'll be talking about is the topic of golden years with a very intentional question mark, because old age is not golden for all older adults, far from it. Social inequalities in later life. And so some of this material pulls from a book that I wrote called Golden Years, that was published about 5 years ago, then a newer book on aging in America. Some of these themes will resonate with the themes of the recent journal issue as well. So, oops, page, that worked, great. And so here's kind of that starting question of our, sorry, I'm getting rid of your pictures on the side because they're blocking my screen. Are the later years really golden? Well, if much of what we knew about old age came from pharmaceutical commercials that come on our TV every night when we're watching Jeopardy, we might think that old age looks like this upper right-hand picture of two married, white, middle-class people sitting on the edge of a boat. And we know that married people have much lower rates of poverty. Very few actually have the capacity to own a boat like that. But that's kind of the image we often see in the media about what old age looks like. And when you dig in a little bit more, we see that there is just as much heterogeneity or variety among the 65 plus population as there is among all of the other populations, right? We have many who are fortunate to be healthy married couples, who are dancing, who have a loving spouse, but then we have others who live in kind of threadbare apartments, who are wheelchair bound, who have difficulty navigating their environment, who maybe have a paid caregiver, if even that. And then again, at the most desperate level, we have those who are unhoused. And there's an astonishingly high level of unhoused older adults. And this is a major crisis. They have challenges finding housing. There's a tremendous shortage of housing. And when we think about the smaller but still relevant population of those who are formerly incarcerated, they often have nowhere to go, right, if they leave prison in later life. Those who are veterans, those who have had substance use or mental health issues, right? There are multiple pathways even to homelessness, as you see in that top picture. So this is just kind of a quick whirlwind tour through these photos to underscore the point that aging is a very, very varied experience, just as varied as any other age group. And so that gets us thinking about the topic, but I'll give a quick overview in this slide about what I'll be covering over the next 30 or so minutes. First, to explain why there's such a vast divide between those people for whom old age is marked by physical vigor versus those who are infirm, those who have opulent and comfortable homes and vacations and second homes, and those whose lives are marked by poverty or economic scarcity. Then also, I'll talk a little bit about a theory that we use in sociology called cumulative disadvantage or cumulative advantage. And I think this is a really interesting concept because it helps us to understand the ways that aging, in and of itself, old age, actually intensifies the harmful consequences of social or economic adversity, right? It's hard to be poor at any age. It is worse for older adults, and I'll say why that's the case. Then on the flip side, I'll talk about how merely normal processes of aging that we're all going to go through are particularly hard for those who are already managing economic adversity. So this kind of perfect storm of biological aging and social inequality can make life very challenging for some individuals. Then, as I mentioned, we can speculate a little bit about the aging experiences of future birth cohorts, because that will help us to think about what their health might look like in old age, if they are even fortunate enough to survive until old age, and what some of the new challenges are. And even though overall we have had population increases in health and longevity for the most part, given technological advances, declines in smoking rates, there are some real threats actually for how future cohorts of older adults or those who are currently young adults or midlife, how they might age. And then we can wrap up talking about recommendations for policy or practice to help reduce these vast inequalities. And I'm eager to hear that lively conversation because I know many of you actually bring much more practical expertise than I do. So I'm really curious to hear how that conversation unfolds. So I'll start with just some statistics on poverty. And if you would just see this chart or listening to your evening news, you might actually think that old age poverty is a problem of the past. And looking at this chart, we see some evidence of that. This is a chart that shows the percentage who are living under the federal poverty line, from 1959 through 2020. And the rates are kind of the same today, but the 2025 data aren't out yet. So if you look back to about 1960, more than 1 in 3 older adults lived in poverty. This was the time period when you would hear the myth, I don't know if it's true or not, that older adults were eating dog food or cat food because they couldn't afford food. Old age poverty rates, as you can see all the way back here, were considerably higher than child poverty rates and working age poverty rates. Now, what happens to that purple line as we progress through the 70s? We just kind of dip down here. It drops precipitously. That is due to the expansion of what? Of Social Security benefits. Social Security started many, many decades ago, but its annual increases didn't keep pace with cost of living increases, and that changed in the 70s. And so there were a lot of problems with Social Security, but as a whole, it is considered one of the most effective programs in recent US history to pull millions of people above poverty. So we see that dip here, gets really, really low. And for about the past, 5 decades, the late life poverty rate has wavered somewhere in the neighborhood of 10%. During the same time period, we have actually seen child poverty, this blue line, increase, and it wavers over time. But if you look at the snapshot today, children are indeed more likely than older adults to live in poverty. And there are a range of reasons for that we can talk about later. But this is a statistic that sometimes policymakers and other people run with to say, older adults are doing just fine. Look, their poverty rate is about 9%. I would argue if you see just that aggregate level statistic, you should still be worried. It's not wholly a good news story. Now, why is that the case? Right? Well, despite all these news headlines that you might see that older adults today are spoiled, they're entitled, they're greedy, they're taking benefits they don't need, even though that narrative is out there, I would argue that this is an incomplete portrait and, in fact, an inaccurate portrait of what's really happening. First of all, if you look at that snapshot of 9%, that belies vast differences on the basis of age, on the basis of gender, on the basis of race, ethnicity, marital status, immigration status, physical ability status. 9% is a snapshot. And what that means is that some people have a poverty rate of about 3%, such as white married men. Other people have a poverty rate over 30 or 40%, and that tends to be women of color who live on their own. So we cannot say that poverty is no longer a problem. And I'm emphasizing poverty because we know that economic factors are implicated in health, the area that you all work in. It has to do with one's capacity to retrofit one's home if they need renovations due to physical limitation, capacity to pay for medications because medications are not wholly paid for by Medicare, for instance. So we care about late life poverty because it links to physical health, mental health, security of one's home, even the quality of one's relationships, because the stressors imposed by poverty can really destabilize or add new strains to our personal relationships. So this is why we should care. But here are just a quick snapshot. We don't have to go over every number here. But as you can see, poverty rates are consistently lower for men at every age group, right? And even for men, we don't see that much variation as we go from the 60s to the 70s to older. For women, we see a steady increase over time. And for the oldest old women in their 80s, the poverty rate is pushing 13, 14%. So about twice that of men who are younger. So age is a factor, and poverty rates tend to go higher as we go past 80, right? Even though everybody gets Social Security, many older adults live on, for instance, their bank accounts, for instance, or workplace pensions if they're still working. People tend to spend down what they have with old age. Certainly, very few people in their 80s are still working, and so they're no longer getting wages or pensions. So again, this is one source of real heterogeneity. Another is race and ethnicity, right? We know that systemic racism has been a challenge in our nation for decades, if not centuries, and it is getting worse, one would argue, in current policy contexts. And so here you can see, again, really profound differences. For all groups, women have a higher risk of poverty than men, right? You can see the dark brown bar is almost always higher than kind of this peach colored bar. And you see, again, tremendous racial disparities, where 20% of Black Americans who are women are in poverty, about 19% for their Latino counterparts, was much lower for other ethnic and racial groups. So again, risk is not evenly distributed throughout the population. So on top of all of that, the poverty statistics that we tend to look at that you'll see in a snapshot report are based on the federal poverty line, which has been a measure that people have relied on for a very long time period. And it's calculated based on your total household income, based on things like the cost of living or the average market basket of food. Now, there have been some economists who argue that the standard poverty measure that we all rely on actually isn't accurate for older adults, because older adults, they don't buy as much food, for instance, but they have very high out-of-pocket medical expenditures from income. So there were some economists who actually developed something called the supplemental poverty measure. That's the donut that you see on the right, whereas the official poverty measure, the one that we all tend to know, is here on the left. And one thing that should come clear to you here is that the blue square here is considerably bigger in the supplemental poverty measure. So even though we've been saying 9% of older adults live beneath the poverty line, that's 15% when you use a measure that is actually better suited to characterize the life experience of older adults, right? Given that they have some costs that are tremendously higher. And so this is just something I put out there as a nugget, right? For those of you who think a lot about poverty measures, this is something that helps us to kind of challenge or recognize the understatement of the problem in the official poverty measure. So when you think there's a question, the graph about is it a good news or bad news story with poverty? Well, it kind of depends where you're sitting structurally. And now we can move to life expectancy, right? Life expectancy is considered another great advancement in contemporary society, and that is absolutely true. Life expectancy is the average number of years a baby born today can expect to live. And you probably have seen charts like this before, but at the kind of the turn of the 20th century, people could expect to live maybe 40, 50 years, whereas today that's been increasing really dramatically. Um, Life expectancy of 40 does not mean that people are dying at age 40. That number is skewed by child and infant mortality. If you have lots of people dying at age 0 or at age 1, that pulls down the average, right? And as people are surviving infancy and childhood, they're more likely to make it to adulthood. So that's one factor contributing to this very steep increase. And the other is that we have better medical technologies, better health behaviors that are helping, on average, everybody to live longer. And of course, there were little dips with the pandemic, both the early pandemic of the 20th century and then the recent COVID pandemic. We've had a couple of other blips with some backsliding for some subpopulations, but on the whole, everybody is living longer. But again, not everybody is living equally longer. So here, this just gives you a couple of little senses of disparities in life expectancy on the basis of race ethnicity here. All of these lines that you see are moving upward, meaning over time, everybody's living longer. Again, that COVID blip notwithstanding, but we actually see really persistent gaps. This orange line is consistently lower than the gray line for white people. The Latino line is higher. That's a topic we can talk about later. It's called the Latino health paradox, why Latinos, even though they face the same forces of oppression and discrimination as Black Americans, their health is better. There's a whole literature on that that we can talk about if folks are interested. But again, everyone's doing better, but some are seeing greater strides, and we still see these really steep disparities in life expectancy. So again, the aggregate good news story is missing some important subplots, if you will. That's race, but also economic differences. I was talking a lot about economic factors earlier, and it's because it's such a powerful influence on health and longevity. So here, these charts show life expectancy over time. And again, as you can see, all of the lines are going up. On the left-hand side, it's men. On the right-hand side, it's women. But you'll see that there's like a yellow line that's higher than green, that's higher than purple, that's higher than blue. This shows that even though everybody's doing better, the absolute life expectancy or survival is far, far higher for people in that top income quartile, meaning the orange line at the top, and far lower for those in the bottom quartile. So again, progress is not benefiting all people equally. Here are these persistent gaps in how long people live. And this has, I'm not even talking about the quality of life, right? This is just simply how long one lives. So that's the scenario that we're at here. Again, we see stark disparities. They don't go away with age, and this is a persistent issue that all of us should focus on. And so now I'm going to talk a little bit about how do these factors come about. And I think if there's one message that you take away here, is that even though economic disadvantage is problematic for all people's health, it is worse for older people because of the biology of aging. So just to walk through a couple of examples here, look at the far left-hand side here. That's a cracked sidewalk. Okay, and if you're klutzy like me, you might trip often on said cracked sidewalk. Cracked sidewalks, they're a nuisance for young people, for midlife people, but, right, and you see cracked sidewalks in under-resourced neighborhoods much more often than a wealthier neighborhood. That cracked sidewalk is a nuisance for young people, it's a nuisance for me. But when people get older and experience biological aging and they have less balance because of heart problems, for instance, they might have an unsteady gait, they might have balance problems. For them, a fall isn't just a nuisance. A fall can be the beginning of the end. Falls for older adults are one of the leading pathways to ER visits, for instance. It renders one vulnerable to slower recovery from other conditions. And again, is something that can be really problematic. So something that seems neutral, worse for older adults. Now we'll move to another picture, especially this time of year. Think about faulty HVAC. Let's say you're living in a building, you're a lower income person, your HVAC, your AC is kind of sketchy, or you can't afford air conditioning. That's unpleasant when you're young. No one likes being kind of hot and sweaty, but it can be potentially deadly for older adults because they are at an elevated risk of hypo or hyperthermia, meaning any temperature extreme is much harder for older adults. In the case of heat, for instance, older adults who have underlying health conditions are more vulnerable to heat stroke. Those who are taking a range of very common medications are more likely to dehydrate from the medication, which makes them all the more vulnerable to heat-related illness. Another factor that older adults face is just biological aging means that you're less likely to cool down naturally. You don't sweat as much. Sometimes if someone's lower income, they cannot keep their medication stored in a sufficiently cool place if they don't have cool, so their medications are not as effective. If someone already has dementia, the heat can create more problems. And we all know that older adults tend to have sleeping problems. Sleeping problems become much worse, again, if you don't have very good AC. And older adults need a temperature of about, 70, 72 degrees to sleep comfortably. If it gets much hotter than that, that can be really problematic in terms of sleep, in terms of cognitive capacities. So again, a seemingly neutral aspect of economic inequality, heat, bad AC, all the worse for older people. And now we think even about another experience that tends to befall those who come from economically disadvantaged backgrounds or from historically oppressed racial and ethnic groups, incarceration, right? This is something some of you might think about more than others. Incarceration is not good for the emotional or physical well-being of anybody, but think about aging bodies. If you have a frail arthritic body, what is it like to sleep on that thin mattress? You might fall off the bunk if you're already physically frail. That's really problematic. If you're standing for call in prison, for instance, waiting for medication, that can be really draining for those who have frailer bodies and frailer minds. So again, these challenges that poverty and economic advantage impose on all people are worse for the health of older adults because of some of these biological, cognitive, and psychological changes that accompany old age. And so what are those biological changes? You all probably know them because you are experts in health, but these are things that are going to happen to most people. And so you can see whereby the intersection of things like temperature regulation being not so great, immune function becoming worse, aerobic capacity, the capacity to stand or walk upstairs gets worse. And so those contexts of poverty make all of these challenges even worse. And so now I'll talk about kind of that flip side of this intersection that I've been talking about. these are some universal vulnerabilities of aging that we're all going to experience, right? The capacity to cool, our posture gets a little worse. These are things going to happen to all of us. But the normal biological aging that you and I and everybody else are going to go through, it's worse for those who have fewer economic resources. So we're kind of flipping that last slide on its head. So we're all going to have more lower body impairments, for instance, but those of us who have plenty of money can afford the assistive devices. We can afford eyeglasses and hearing aids and a nice walker. Those who are wholly dependent on public insurance don't necessarily get the best assistive devices. We like to think that Medicare covers everything. No, Medicare A only covers a subset of things that older adults need. If you want Medicare Part B, which covers walkers, crutches, hearing aids, etc., you have to pay extra for it. And that's something that not all older people can afford, right? So that's one dimension of natural or normal aging. Another factor of normal aging that all of us are going to experience, which is kind of diminishing immune systems, right? Older adults, doesn't matter how much advantage you have, you're all going to have a diminishing immune system. The extent to which it affects our lives is actually worse for those who have more social challenges. So just to give a couple of examples, we know that there are many older adults who are living with a sole custodial parent to their grandchildren. And this is a case, again, that tends to affect communities with fewer economic resources. Oftentimes the child, the person in the middle there, or the grandmother's daughter, for instance, who's the mom of the little boy in this photo, if she has substance use issues, premature mortality, incarceration, opioid use, when she's taken out of the scenario, right? Grandma is now responsible. And just think about that. You have a diminishing immune system, and your child is coming home from kindergarten or first grade. We know they're kind of little germ magnets at that age, rendering their grandparent all the more vulnerable to infectious disease like COVID. So that's another example. Then the final example to give is ageism, right? We might not like it, but we are all going to get gray hair as we get older. Maybe our teeth might discolor a little bit more. We will have more lines in our face. Our bodies will be a little bit more hunched over, right? As we develop things like osteoporosis. Um, that's something that tends to happen earlier for people who don't have economic resources. And so that's a reason why ageism, even though we're all going to experience ageism tends to be worse for people who have fewer economic resources. Again, so ageism meaning you can't get a job because you're old, people talk down to you, for instance, because you're older. This is something that I would argue affects people with fewer, again, social and economic resources. Now, why is that? We're ageist to people who look old. And who looks old? Those people who cannot afford the colorist, those who for their hair, those who can't afford facial moisturizers, teeth whitening, the aerobics class or the yoga class that gives you good posture. So again, those who face more economic adversity are more likely to be subject to ageism. And in many cases, these are precisely the people who need to find a job to pay their bills, such as working at Walmart, working at a convenience store. These are precisely the people who might need work but who are not getting it due to pervasive ageism. And so these inequalities I'm talking about, an important theme is that old age inequality does not emerge magically on someone's 65th birthday, right? Poverty and the health problems that accompany it often have roots very, very early in life. And there's a theory that I referenced earlier called cumulative disadvantage theory. When people are growing up, you and your best friend from kindergarten might have lives that are pretty similar, right? But over time, let's say you had the opportunity to go to college and get a master's degree and get a good job and health insurance and a home in a safe neighborhood. That trajectory leads to a very different old age than the friend who maybe dropped out of school in 11th grade, took a manual job that's really hard on their body, maybe doesn't have the good insurance, maybe has a marriage that was destabilized by economic strain. And we know that divorce is something that undermines one's economic prospects. So you can really see whereby small differences early in life really can escalate over time. And so we have this scenario of the haves and have nots. And I think this is really important to recognize because it means that giving people Social Security in old age or giving lower income older adults supplemental income in Medicaid, it's a band-aid to the problems that start much earlier. So old age health policy really needs to start earlier with nutritional policy, educational policy and housing policy so that everybody has that opportunity to age well. I think I'll skip those at that one in the interest of time. And just to kind of walk through just a point I think is really important here, and again, as health researchers, you have probably deep expertise in this, but Medicare is wonderful. Medicare, that federally provided health insurance for older adults, again, an amazing resource that is necessary. It's important, but it's not a panacea. It cannot cure all of these problems that I just mentioned. And one reason why is that health problems have their roots much earlier than age 65. If you look at people who have led lives of economic adversity, for instance, who have difficult jobs, who can't afford a high quality diet, they might have diabetes onset at age 40. They might have back problems at age 45, for instance. They might have early onset arthritis. And so they have these health problems earlier. It might prevent them from working. And waiting till age 65 to get that health insurance really might not be an option. And so this is something there's a lot of research on. This normal biological process of aging that we're all going to go through is hastened by social and contextual stressors. And there's a concept that you might be familiar with called accelerated aging. Our bodies age quicker when we live under stressful circumstances. Even extreme heat, there's new research on that. Climate change is leading to accelerated aging for all older people, but especially those, again, who can't afford, housing that is safe and secure. Another issue is that, yes, Medicaid does step in. It does provide health insurance coverage to lower income populations for those who are young. But even then, the access can remain spotty. And sure, some of you work with clients who say, well, I can't find a doctor to take my Medicaid, or they're 3 bus rides away. And so even though we have on the books this policy that provides health insurance to lower income people, not everybody can access it. And there's tremendous regional variation. According to some of the latest stats I've seen, about 70% of doctors in the US will accept new Medicaid patients, but those rates range from about 40% in places that are costly, like New Jersey or New York. The Medicaid reimbursement to doctors is so low that it's often not worth their while to accept those patients. In a place like Wyoming, where the cost of living and cost of doing business are lower, almost all of them will take the Medicaid patients. So that's something that's really important. Then the next point, also just to underscore what I just said, Medicare coverage is superb, but it's not comprehensive. For those who can only afford the main Medicare, as they think about it, there's no dental benefits, right? There's the donut hole. It doesn't fully cover their prescription medications. Long-term care benefits are not covered. So again, there are these big holes in the healthcare that older adults have access to, the healthcare coverage, sorry, that they have access to. So now in the last maybe 5 minutes or so, we'll talk a little bit about just future trends and policy considerations for the 21st century. The challenges that we see in front of us right now are going to persist, right? And in the current policy context, perhaps we will not see much improvement in the things we would like to see improved. What we have seen over what I find most troubling is perhaps over the last, 4 to 5 decades, we've seen an even greater bifurcation of the haves and have-nots. So old age will continue to look really pretty good for people who have money and health insurance and safe homes, but for others, it's not going to look that rosy. And I think this is a really important theme that we always need to keep top of mind when we think about social trends. This is a chart that some of you might have seen before called rising income inequality. And in short, what this means is that the gap between the haves and have-nots have widened dramatically. So if you look back here in the 60s and 70s, the rich were always richer than the poor. But starting in the 1980s, as a function of Reagan era tax policies that benefited the rich and did not benefit everybody else, the capacity of rich people to invest and to buy homes really escalated, for instance. And so we see that this gap here is getting bigger and bigger. And what that means is that those at the very top here can drive up costs for the homes that they want and the healthcare that they want and the college tuition for their children, leaving others behind. And so this is an issue that's really going to affect future generations in their capacity to, for instance, amass wealth. We know home ownership is really the resource people have to pay for their long-term care. So I would argue whatever disparities we're seeing now are going to get worse across future generations because of this widening income and wealth inequality. Current attacks on the social safety net, again, at all ages, from Head Start programs to early life nutrition. That's something that's also going to matter for the long-term health and well-being of the cohorts that we see aging before us. Um, um, Another theme that I think is going to matter for health is climate change, right? Oops. Here we know that the number of natural disasters has been escalating dramatically. We know that it doesn't matter if it's a heat wave, a flood, a drought, the impacts are worse for older adults. And on top of that, they are worse for disadvantaged populations. So as we do see more weather disasters, it's going to affect health of people at all ages, but especially older people. It also will have economic consequences for younger people, for instance, as their insurance rates for their homes go up. The creation of things like mold in buildings will compromise the health of younger people, making it difficult for them to age. So that's another factor that will have both short and longer term implications for the health and well-being of cohorts of older adults. I guess another big trend that I think we have currently that is only going to escalate in the near term is we have 75 million aging baby boomers. We will have a lot of aging millennials because that's a very large cohort. We do not have sufficient numbers of caregivers to care for them, right? Family caregivers are diminishing because people have fewer children, if they have children at all. As people's marriages end, or if people choose to not have a permanent romantic partner, the usual suspect caregivers are diminishing. So we have lots of older adults, many of whom will need care, but we do not have enough family caregivers. On top of that, we have a tremendous shortage of paid caregivers, right? And as we have increasingly restrictive immigration policy, that supply of immigrant caregivers is, of course, going to diminish. And I show you this slide here because I just find it really fascinating. This is a slide I use every year, and every single year, whether it's 1924, 2024, 23, etc., the same job sits at the top of this list. And so this is an occupational projection chart from the Bureau of Labor Statistics. Every year they project the job that we're going to need the most of. And every year the same one sits at the very top of the list, which is home health aides and personal care aides. We need, again, about 820,000 home health aides to meet current needs. And people are not going into this field. And when you ask why are people not going into this very, very important field, well, look over there at median pay, $35,000 a year. This is a job that's largely held by women, immigrant women, women of color who are barely paid a living wage. We need this job to care for our large and rising numbers of older adults, to keep them comfortable and to keep them healthy and to have them take their medications that they require. But there's a shortage and it's only going to grow worse. So this is yet another challenge facing the care of older adults. So what can we do about it? You all are the experts, so in the Q&A that follows, I'll be really curious to hear some of your thoughts. I am among those who believe, yes, we need to expand Medicare coverage. We need to cover those sensory impairments like dental, hearing, and vision that are so important. A couple of years ago under Biden, the Reinvigorate Social Security Act was 2100 was proposed to really increase minimum Social Security benefits. We want to make sure that those at the lowest end of the income distribution get those boosts in Social Security benefits. I hope these kind of programs persist, but we don't know. Getting back to Medicaid and Medicare. Could we bring Medicare down to people who are age 55 or 50 to address that issue that those who have more economic adversity get older and sicker at younger ages? I don't know the political feasibility of that right now, but for some people, 65, it's too little too late. They need that assistance at age 50 or 55. Other things we could do from a policy standpoint is to increase caregiver benefits, right? To the extent that we have some family caregivers, a lot of them can't give care because they have to work for pay. They have to support their own families. And we have rising numbers of states that actually are offering paid family leave and public insurance programs for those who are family caregivers. Here's the list of the states that have it. They tend to be blue states like California, Rhode Island, New Jersey, New York, etc. Delaware, Maine, and Minnesota are being added this year. But I think that's something that's a small intervention that could make at least some strides in helping older adults be appropriately cared for. Then there are more innovative public-private community initiatives. Things like Senior Corps, there are volunteer programs that help older adults to stay engaged. And there's actually data tracking what happens to the volunteers in the foster grandparent and senior companion programs. And their physical and mental health actually improves during the duration of the program, and they get a slight stipend for doing so. So that's something that's private, public, that can have mental health benefits in terms of social engagement to help fight social isolation that many of us would like to see kind of continue to be funded. Meals on Wheels brings meals to people's home. Again, we'd like to see that suitably funded. Even innovations like co-housing in villages programs where people, older adults, can stay in their homes, but it's almost like kind of like a Golden Girls kind of fantasy that you all live in your own homes, but then you share skills. If you're a good cook, you'll bring meals to your neighbor, and your neighbor will help you to use the Uber on your iPhone, for instance. Ways to help each other to maintain health and independence is something that also is a good idea. Get AmeriCorps, that's another volunteering program for older adults that gives them an opportunity to stay engaged. AARP actually has an experience corps that provides modest stipends for low-income participants. So there are lots of these smaller programs that are helping to provide social opportunities that are health enhancing. There are ways that some older adults who have few resources can get a little bit more of a stipend. And so these are all wonderful programs that I think many of us would like to see scaled up because they have demonstrated themselves to be effective in trials that track the progress of participants in those programs. And then just one final little nugget I'll put out here before wrapping up is one thing that anybody who works with older adults has to have top of mind is climate change. We know that every part of the country in the world is getting hotter and hotter. This is something that's going to happen. And the impacts for older adults can be dire. And so those who work with older adults just really need to be kind of climate sensitive. If an older adult is really warm, they might not be comfortable moving to a cooling center. They don't know where it is. They can't get there physically. They might not be able to use their iPhone to get those messages telling them to evacuate. So we really need just tremendous attention to training our workforce to recognize these new health related needs and concerns that older adults have during moments of extreme heat or extreme cool or other types of weather disasters. Again, that's just a certainty of something that we will continue to see coming down the pike over these next few decades. I'll skip that in the interest of time. So thank you for listening. I know there was a lot of material here, hopefully lots of nuggets to generate further conversation. And I look forward to hearing your thoughts and talking further about these topics or related topics that are of interest to you. So thank you for listening, and I will stop the share. It is stopped. Okay,
Yeah.
there we go.
Yeah, you're good. Thank you so much, Debbie. That is, I mean, just absolutely fascinating and really, really important information. And I think, given that much of our audience here, our participants are public health, I think they really appreciate the attention on emergency preparedness, because that is something that even a local public health practitioner can attend to, right? And making sure that they're thinking about older adults when they're developing those emergency preparedness plans, which they all have to do.
Yeah.
I'm going to open the floor up now to any questions or comments. I know Dr. Carr would love to hear from you all as well about your thoughts about this area and cumulative disadvantage and the impact that that's going to have on all of us and our communities and how you all are preparing for that. So would love to hear from you all.
Hello, my name is Dana Paperman. I guess I can turn my video on.
There we go.
I am the executive director of the Seward Senior Center here in Alaska. We are a rural community at the end of the road,
Yeah.
and we host the Nutrition, Transportation, and Support Services federal grant, as well as health promotion federal grant. And we came into 10 years ago running the commodity supplemental food program in partnership with an Alaskan food bank. And that's part of Second Harvest and federal funds, and USDA is the driving force. concerns in regards to, good nutrition, for, older Americans is one of my concerns is these food boxes that go out to older Americans. Um, we, I really like to encourage that we could find the ability to give them more access to fresh foods, and keeping them, healthier and having that roughage in, in their day-to-day nutrition. So that's just my concern, to just be able to take, to the policymakers, and we have a lot of individuals that don't participate in that program because they don't eat what comes in that box, and so we're missing a target audience, and also the concern of elderly individuals is being able to move that 40-pound box from distribution site to their pantry. That's
Mm.
also a physical challenge. I just wanted to bring that to your attention. And thank you. This was a very valuable presentation today. Thank you so
Thank you.
much.
Thank you for those remarks. It's nice to meet someone from Alaska. I am in Rhode Island, so we have the largest and the smallest here
Yeah.
simultaneously. Yeah, those are great points. I think there's so many issues that they need the healthy produce and they need food that matches their diets, right? Many of them are very particular diets. And then the oral health needs as well, right? Chewing some substances are really hard. And especially during the pandemic and in other places where there's a shortage of volunteers, essentially they have to bring them the boxes and the freeze dried meals because it lasts. And I think this has also been a kind of a volunteer workforce issue to get them the food they need. And one program I've seen work well, but at a very small scale in some places, is community gardens. So the community gardeners will donate that healthy food to the local food bank, but it tends to be on a very small scale. And that's a kind of investment that, if we had the human resources and the capital resources to get that food to the older adults, put it in smaller boxes. And then the other issue is culturally sensitive foods, right? There are some dishes that some people just don't want to eat. Some people will
Mhm.
not eat collards. Some people love collards at our community garden, for instance. And so, I think you raise a really important point about the practicalities of essentially distribution and the reality of aging minds and bodies and diets, right? And this is something that, as much as it's great to give food, we want it to be food that they will eat and will access. So thank you for that.
Yeah. And I think there's another issue here too, and that is that there are a lot of older adults who are eligible for food boxes, for support, for SNAP benefits
Yeah.
that don't know it and don't sign up for it. And so I think it is incumbent on all of us as well to use whatever messaging vehicles that we can to ensure that people who are eligible sign up for those benefits.
Yeah, that's a great point. I just reviewed a book. It's a new book that just came out. It's not my book, so I'm not making an advertisement for it, but it will be coming out with Russell Sage Press by Madonna Harrington Meyer and Colleen Heflin. And it's on exactly this, on older adult food insecurity and why the
Mhm.
SNAP rates are so very low. And you're absolutely right, Megan. It's a messaging issue that some don't know about this.
Yeah. Yeah. Thank you. We'll look for that book. Send us that link when that gets published.
Yes, I will. Yes, I
That'd be
just got
great.
my desk copy, so I think it should be
Okay.
available soon.
Excellent. Other questions or comments? I'd love to hear from you all. And while we're giving folks a chance to think about that, Debbie, you participated in an event that we hosted in Washington, D.C. in June, our Age-Friendly Ecosystem Summit, and really appreciate your participation and on that panel. One of the questions that we asked was of you then, and I want to pose that now, was if we're thinking about this age-friendly ecosystem and different sectors working together, like what can we do? What can sectors, how can people work together across sectors to address this issue of cumulative disadvantage and thinking about people aging better at an earlier age, like aging more healthily and living more healthily at an early age? How can our ecosystem collaboration efforts, how might that be made more effective?
Yeah. That's a great question. And my answer, which is kind of an academic answer, might not be feasible in terms of the way services are divvied up. And then also in terms of timeline, like I think collaborating with organizations that serve younger populations or working age populations, that will not help older adults today necessarily. It will help them in the longer term. So I think that's one way to think about it, that, a SNAP program for young people or farmers market or school intervention program for people today who are younger, or school retention programs, for instance, will bear on them for the longer life course. But I'm actually going to correct something I just said. I said it might not have any bearing on older adults today. It actually will. And I think one thing I often write about is that we often think that the generations are pitted against each other. If we fund a program for older adults, that's not going to help young people. That's completely not true. If we keep young people healthy, they will be able to care for their aging grandparents. Likewise, if aging grandparents are healthy, they can care for their children. In some cases, if they're financially sound, they can help defray the cost of school, for instance. So the generations are inextricably tied to one another. And so I think help programs, if we just change our mindset that help one generation, will necessarily help the neighboring generations at the family level because they're so intertwined. So that's kind of one recommendation. The other is just kind of partnering across domains. Like I've often seen that the housing people might not necessarily talk to the healthcare people, to the mental health people, to the suicide prevention hotline, which we know, again, suicide is a big issue for older men, much older
Mhm.
men, for instance. So thinking about kind of cross sector in ways that maybe isn't done as tightly. Also kind of engaging the first responders, for instance. And then the business community. I mean, I think they often get a free ride. Like now the federal dollars for things are kind of, I don't know if I can say that. They seem to be minimizing or going away. Think about the role of businesses. What vested interest might they have in supporting programs for older adults? And I think that's important because we've all seen the data on charitable giving. People don't give to older adult organizations. They like giving to children. They like giving to animals. But for whatever reason, organizations that serve older adults have a lower rate of charitable contributions from some of the data that I've seen. And so maybe that's another issue of those organizations or foundations that are prepared to make these contributions. That could maybe be another way to approach this. But
Yeah.
again, a lot of these things are easier said than done.
Well, it's good though, because I think that's, it could generate other ideas, and planting those seeds in our minds, I think, is helpful. So from Lindsay in Hawaii at the Hawaii Public Health Institute. Hi, Lindsay. Glad you're here with us today. Lindsay says that in Hawaii, they're ramping up their efforts to address the cumulative disadvantage experienced by older adults exacerbated by climate change. Are there any resources or communities of practice that we should tap into?
Hmm. That's a good question. I honestly think it's still pretty decentralized. I mean, the one report, I mean, that gives information and helpful suggestions that I think has been the very best is one by the World Health Organization, because they're thinking about this at kind of a global level, and they have actually really good and helpful practical advice pieces in there that could be useful. Um, Double ARP is another one. And then every state, or at least most states, have kind of a climate plan. And there's a website that I can dig up and send to you all later that lists what it is at the state level. And so those are some of the better practices that I've seen. I assume also maybe AGS, the American Geriatric Society, have best practices. The social science side, the Gerontological Society of America, we're getting on this and we're doing research, but I haven't seen many practical kind of hands-on kinds of documents. So I would say that World Health Organization report that came out, I think in about 2021, will be particularly helpful.
Appreciate it. Thanks, Debbie. And then Catherine Davis from Santa Rosa County in Florida, who's one of our healthy aging and our APHIS champions. Thank you, Catherine. So says that she's created a healthy aging brochure with widely unknown resources listed and an emergency visual checklist for older adults to prepare for emergencies that are incredibly popular. And we'd love to have you share that, Catherine. Kathy, I'm going to call you Kathy. I think that a lot of people would really love to see that. So if you have a document that you can share with us, if you can email it to us, and Karan, if you want to drop if you wouldn't mind dropping your email address in the chat so Kathy can send that to us and we can share it out when we send out the slides. That would be super helpful. So thank you for
Thank
that.
you. I would love to see that as well. Thank you,
Yeah,
Kathy.
yeah. And so Christy Fuller, also with a Public Health Institute in Georgia, can you speak to differences you might be aware of or seeing in the data with regard to older adults aging in rural versus urban communities? Great question.
Yeah, thank you for that. That's a great question. And there are disparities along almost every dimension. And by and large, older adults living in rural communities are faring worse for a range of reasons. One is that kind of with the outmigration of younger people and families, sometimes they don't have that support they need from families. Although if it's a small, close-knit community, they will find family-like people. But some of the big issues really are access and infrastructure. That is a very big one. So one is even internet connectivity. Like today, most resources, whether it's signing up for Social Security or getting a ride service, is done online. And there's still some pockets in rural areas that don't have very good connectivity for those older adults who need that. Another is the access and delivery of services. And one area in particular where you see this as being really quite acute is hospice. And we haven't talked too much about hospice today, but rising numbers of older adults don't want to die, as they say, connected to machines, and they need comfort care at the end of life. And in rural areas, oftentimes they don't have many hospice providers, or there's some places that the hospice nurses might not necessarily serve, given that how they're paid, right? It's very costly to drive because they're paid for their time. 50 miles between homes. And so sometimes they might not have that access. Whereas in a more urban area, they can go visit from house to house to house. So that's another area. Another issue, elder abuse, it's rampant everywhere, but in rural areas, it tends to go less well detected and treated. And one of the reasons why is the communities are so small. So someone might be abused by their spouse, while their spouse is also the former mayor and the postmaster, and everybody knows them and they know the police officers. So that's another issue. It tends to be reported a little bit less. And they might feel, really stigmatized, and they might not be the service providers. And then, as Kara just said, another real common one is lack of transportation, right? And again, if there are cuts there, if people cannot drive or should not drive due to either vision or reflex time, and they're getting their licenses taken away, they can't get to where they want to go. And if there's not that van to take them to the doctor's appointments or Walmart or wherever they need to go, that's another real issue. And so their just daily needs will be unmet. And part of it is procuring the groceries, as we just talked about, and the medications. So a lot of really significant challenges.
Yeah, absolutely. Well, this has been absolutely fantastic. Dr. Carr, thank you so much. Just been very insightful. I think there's a lot of information here that people probably were surprised about. So we really, really appreciate that. And your responses to all these questions been so interesting. I'm going to turn this back over to Karan to close us out with a few more, couple of ending slides. So Karan.
Right.
Thank you, Megan. Thank you so much, Dr. Carr. Even though this is not a data presentation, I love the numbers. So thank you so much and enjoyed it. For those attending, thank you again. Our next training will be on September 18th at 3 p.m. Our speaker will be Alison Barkoff, who is with a professor at GW and former ACL officer. And for those of you pursuing champion recognition, please take a minute to pause the recording or pause the training right now. And if you're attending live, please just navigate to the QR code or use the website on the screen to indicate that you are here and that you attended our training. And again, you have to indicate that you attended so that we can count it towards your 6 to become a recognized champion. We have over 200 champions now, so please make sure that you become one of the many growing number of people across the country that are recognized. And again, here's our contact information, our website. Thank you again for joining us this afternoon.
Thanks, everyone. We'll see you next month.